welcome everyone to the One Society Network seminar series. As you all know, my name is Ellen Rafferty and I'll be facilitating this session today. And I would like everyone to join me in welcoming our presenter, Dr. Snowdon. Dr. Snowdon is a professor of strategy and entrepreneurship at the Odette School of Business, University of Windsor. Dr. Snowdon is leading a national research program focused on the capacity of health supply chain to enable health system responses to the COVID-19 pandemic in 7 Canadian provinces. I think we're all hearing about this in the news these days with the restrictions on pharmaceuticals, especially pediatric pharmaceuticals. So I think it's a very relevant topic. And so today's topic is the impact of supply chain capacity on health system response to COVID-19 in Canada. And this presentation will share the outcomes of a national research program of work conducted during the first 3 waves of the COVID-19 pandemic, features of supply chain fragility, and opportunities to advance supply chain resilience will be explored. And just before I begin, a bit of housekeeping. So please submit any questions during the webinar using the Q&A function instead of the chat function. Feel free to submit any comments you have. You'll be muted throughout the webinar, so that's the best way to submit questions is through that Q&A function. And we'll answer those questions at the end of the presentation, so we'll definitely save some time to answer those questions at the end. And that is it. So thank you again for joining us, and I will hand it over to Dr. Snowdon.
Sorry about that.
No worries.
Thank you so much, Ellen. It is absolutely my pleasure to be with you today and share these results. And Ellen, you're quite right. There is constant news about supply chain shortages. So this presentation really just captures some a fairly in-depth deep dive of what in fact is the capacity and resilience of Canada's health supply chain. And based on that evidence, where in fact does it help us and drive towards a much more resilient future, I guess, that we can all be confident in. So let me walk through what are highlight of the key findings, and very much look forward to your thoughts and your insights, and even your interest in joining us perhaps in solving some of these pretty significant challenges for all of us. So let me start with, what did we set out to do? This was a CIHR rapid response type of research. I think you'll all recall that those proposals were called for at the height of some of the very dramatic and compelling early phase of COVID. They gave us, I don't know, 10 or 11 days to write the proposals and 2 weeks responses. So one of the things we've all learned in CIHR is no exception. When you have to get busy and develop and create evidence when it's desperately needed, Canada is able to do that. So that was fantastic to get that support. Our objectives were to really set out and create a comparative analysis of our provincial health system supply chain infrastructure and processes that drive and enable capacity to deliver care. And that's something we don't always think about in healthcare research and health services research, which is the institute by which I had been on the board at one point. But if you don't have the products, the critical products, equipment, tools to deliver patient care, quite frankly, I'm a nurse by training, it doesn't matter. We can't be very effective at meeting people's health needs. So this is a strategic asset in health systems. Our goal here was to figure out to what degree do our supply chain capacity really have the capacity to respond when it is so most desperately needed. We looked at policy frameworks as well in terms of where and how those support and enable supply chain capacity. And we looked at where there was opportunity and evidence of coordination. We have 13 or more health systems in this country. The question is, to what degree did they work together, or were they all working pretty much standalone, which is somewhat classic in the Canadian health system. What we did then were we completed 7 provincial case studies: BC, Alberta, Manitoba, Ontario, Quebec, Nova Scotia, Newfoundland, Labrador. The only reason it was 7 was it was literally, I had a very short window of time to get to connect to provinces and see if they would be willing to participate. And seven of them quickly jumped at it and said, absolutely. And the others, I just didn't have enough time to get to. But sadly, had I been able to, I definitely would have. What we looked for was evidence of supply chain capacity infrastructure that enabled responses, of course, to this pandemic. It was a qualitative study because there is almost literally no such thing as quantitative supply chain data that is A, publicly available, or even B, with permission available. I spent all of the 12 months of this study trying to secure supply chain data. You'll see in a few minutes why it was impossible and I was not successful. So 152 qualitative interviews. We interviewed as broad and diverse a group of stakeholders as we could. Supply chain leaders and teams, health system leaders, federal and provincial government leaders, clinicians, health organizations, CEOs or vice presidents, public health agencies, home care, community care, long-term care, health workforce, union groups or associations as well. It's a grounded theory methodology where we really analyze themes that were recurring across interviews within each jurisdiction. And then subsequently on a second round, we went back and did validating interviews with some of those very same stakeholders, and then did an analysis, a meta-analysis across those provincial case studies. So what I'm going to talk about today is really the analysis across the 7 provinces I think it's the greatest value in terms of what the key findings were. There's no question, this won't surprise anybody, that there are substantive features of supply chain fragility in Canada. We are not unique to that, by the way. I have worked with a number of countries since this study and even before, and virtually every country struggled with supply chain capacity challenges. I just recently gave a presentation with a colleague in the US comparing Canada and US, and one of the comments in the audience was, and you could have been talking about US, absolutely everything happened the same here. Of course, the scale and scope is quite different. But this is a summative list of really where are these areas of fragility. One is for sure the very decentralized or less connected leadership, supply chain leadership, I'll speak to in a moment. The reliance on just-in-time, which we've heard about and works very well in manufacturing as an incredible cost savings measure. Just-in-time, however, did not actually produce the capacity to respond quickly to surge in demand. Single sourcing, single jurisdiction sourcing. So 90% of products, critical products for a pandemic particularly, in North American health systems were all sourced and procured from China. Of course, that was the jurisdiction that shut down first during the pandemic. So you created this massive, literally door slammed on all sources of products that every health system in North America accessed. So it wasn't just, we happen to use that company, we should have used another company. It was an entire country. Supply processes being very manual, lack of product and standardization of data. I'll speak to that in a moment. And a very reactive supply chain strategy, which I'll also speak to, but waiting for the shortage to happen and then trying to figure out how to manage that shortage. And that's one of the outcomes, I would say, of many of these features of fragility that I'll come back to in just a moment. So if we look at each one separately, I think it's probably the greatest value. In terms of leadership, now, if you think about it, Canada is one of the smaller populations in the world, of course, spread across an exceptionally large landmass. And that would suggest that our volumes are smaller. So when we compare the volumes of products used in health systems in Canada compared to that used in Germany or England or Australia, well, not so much Australia, but maybe US, we're really small. So a decentralized leadership strategy means there were leaders in each of the provinces and multiple leaders. And back to the case of Ontario, leaders in multiple organizations, all working independently. There was no coordination, collaboration, which creates significant challenges, of course, in terms of competition. If the world is short of PPE, for example, if every hospital CEO or every community care agency or long-term care organization is competing with every other one within their province, and all the other provinces and all the other countries, then it's a profound limitation. Long-term care community agencies were, without exception, not prioritized relative to their hospital counterparts in virtually every province. And that was shaped by and influenced by, many of you recall those images we saw on television of Spain and Italy and the devastating outcomes of in the early wave of COVID, of course, of so many patients requiring care. The initial response in North America and of course Canada particularly was, let's shunt all of our short products in short supply into our hospitals. That's where we're going to need it most. Well, of course, that's exactly what it was a good thought, but it certainly didn't prove to be very helpful, particularly for long-term care, and I'll come back to that. Also, there is no data infrastructure. So as leaders were desperately trying to source and find the products and figure out what products do we need most, there's no data to help them and do that. There is no province, except perhaps Alberta to a large degree, that could produce a document to say exactly how many masks do we have, here's how many we're using, here's where we're using, here's where our gaps are, and here's how many hours, days we have before we run out. Data infrastructure is profoundly limited, so it wasn't as though leadership had any opportunity to make data-driven or informed decisions here. Decision-making across leaders, we could not find evidence of that in different provinces, although when Ontario got into big trouble, of course, Alberta, well, we all know, graciously stepped in and sent supplies to them because Alberta was far more prepared than Ontario was. The other, I think, interesting finding and important finding to reflect on is the fact that there were many leadership decision-making tables in every jurisdiction, sometimes multiple in one jurisdiction. But I could not find a leadership decision-making table where supply chain experts were at that table, with possibly an exception in Newfoundland. But generally, the senior level decision makers tended to be system leaders and or provincial premiers and their teams. Supply chain tended not to be at those tables, and nor did clinician expertise at those tables. So that was a challenging. I would suggest that contributed to the fragility and the leadership challenges that most leaders faced. The other thing, we could not find evidence of any learning from SARS. Many of the recommendations from SARS, there was over 200 of them, literally showed up almost exactly the same way in this pandemic, but a much larger scale. A second feature of fragility that was crystal clear was the destabilization of supply chain sources. That, of course, makes a lot of sense. The catch is there weren't really any backup plans. So if all of your product sources from Japan or from China dried up, and as they did, I could not find evidence that other provinces had backups or multiple and different sources of products they could rely on. So of course, just-in-time supply chain model, which is something we've known well in Ontario here, it's very significant and important model for the automotive industry, proved to be completely not viable because it couldn't respond to surge in demand. What also happened that I don't think we prepared for or thought about was what I call the global me first tendencies, where world leaders would just shut their borders down to allowing any company to distribute products out of their company, out of that country jurisdiction, in order, of course, to protect their own population. We saw that in the Trump presidency when 3M was not permitted to ship any N95 masks out of the US. So that created a significant destabilization. Very significant shift and rapid shift towards building and support and finding alternative sources was obviously needed. Some turned to domestic manufacturing, which actually proved to be incredibly important. In some provinces, companies that would formerly make clothing of some type would switch to making gowns, or other companies would switch to making masks or face shields, literally provided a runway for those health systems to enable them to find other sources globally. So domestic manufacturing played a very important role. Many provinces went to other geographies and have since procured from those geographies and plan to have multiple different geographic representation of their sources, which will in fact overcome some of that fragility. The business community stepped up in a significant way, particularly in some of our smaller provinces in the eastern part of the country. Newfoundland and Labrador business leaders came together, independently created a network to go find these PPE products through their supplier networks, and they were actually impressive in terms of their success. And of course, every system shared with us the overwhelming response of Canadians on donations. People donated, we all saw people sewing cloth masks in an effort to provide any protection, or finding, masks from other business sectors and shunted them all to the health system. Of course, what we don't always think about in that generosity is it's exceptionally challenging to manage that volume and effectively manage that volume of donations so frequently. So that proved to be helpful, but also exceptionally resource intensive. No question, the capacity to meet surge in demand where it was needed and when it was needed was not there. Canada was not prepared to source and provide the critical products it needed as fast and in the volumes it needed it. The very early signal that something was going on was reported by a couple of the Western provinces, who suddenly noticed their orders into the supply chain team rapidly, unexpectedly increase. So instead of a surgical unit that would often order 10 boxes of masks, they were ordering 1,000, but with no apparent explanation. And that was in December. So supply chain teams had an inkling that something was unfolding, and much of these supplies, of course, were flying off the shelf when formerly they just didn't before. And that was really a reflection of the erosion of staff confidence. Staff would get their hands on any, masks or gowns or gloves and keep their own little stash so that they would be protected. And it was their confidence in the ability of the system to protect them. What they shared at the time was limited. The increase was dramatic. Having said that, one of the provinces, Alberta, has shared quite openly. On an average day in Alberta, the entire province uses 33,000 surgical masks per day. That increased in the first wave to 760,000. It has remained, I think, still over 400,000 even now, and that's one of our smaller provinces. So you get a sense of the magnitude of that surge. GPOs, supplier contracts, were not an option for most of the provinces. They were having just as much difficulty finding those sources of product. They were locked into contracts with provinces for a set number of products, like 33,000 a day. They could not surge and meet demand. So what they did was simply meet their contract demands with some challenge, actually, and couldn't move beyond that. Conservation strategies was common in every province. So in the face of a shortage, of course, those decision-making tables sat down and said, okay, how are we going to manage shortages? And what they essentially did was create an allocation strategy. So they would determine for those clinicians, here's what you are permitted to use for your care. So they would be, in some cases, they were given a bag of 2 or 3 masks for the shift, or 1 face shield, or whatever it was. And that was profoundly challenging, because that was, and I'll come back to this, but that essentially removed the decision from clinicians to make the best, evidence-informed decision on what do I need to be protected and to protect my patients. That went out the window, and in turn, it was reasonable to understand why and how that happened. What the problem being, a moment ago, I said there were no clinicians at that decision table. So the allocation framework was decided without clinicians at the table. The implementation of that allocation framework then became profoundly problematic, because it was now no longer possible for a nurse or a physician to determine how to make sure they were safe in the work environment and their patients were safe. Data and infrastructure resulted in a lack of transparency, of course. So if you're working in a particular hospital setting and you have no idea if you're going to have access to a mask as that next patient with COVID is being admitted, you start to become exceptionally concerned about your safety, the safety of your family, maybe your loved ones at home or your elderly. parents. So people had no line of sight to, do we have any products? Are we going to have any of this protective products tomorrow? Or am I just sort of on my own? And that really eroded the confidence in the workforce. Many provinces, of course, struggled with no data. How do you go out and source product when you don't know how much we're using, how quickly we're using, and what products are most desperately needed? Many provinces created manual counting. So in Ontario, where I live, nurses would count the number of masks they had available on their clinical unit every day, put it in an Excel file, email that Excel file, and that became what was known as Ontario's virtual inventory. Well, if you're a nurse in an ICU setting and you have 1,000 masks, but you really don't want anyone to take some of those masks and take them somewhere else, you may find that you don't exactly accurately count. I have no evidence to say that's exactly how it happened, but lots of people suspected that it was problematic to expect people to be counting those things every day in the midst of so many other stresses in the system. Very high variation in provinces. Many, eventually by wave 2, 3, most provinces had some type of a digital tool that could tell them how much we have and approximately where we have it. No province had the actual real-time line of sight where you could go onto that dashboard and look at exactly where you have how many masks, what unit, how quickly they're being used. Although there are some provinces, Alberta being one of them, making rapid progress towards that. There was no evidence of interoperability of systems. So there was no province or jurisdiction that coordinated or shared any data across any other jurisdiction. Everyone worked very much on their own, and data sharing was particularly just non-existent that I could find. Standardization of data is a feature of this. One government leader who was leading procurement and trying to find sources of gloves masks for his particular province shared. He said, yeah, I just realized how limited our data standards are. And he went on to explain that he found that there was 56 different names in the inventory catalog for one type of mask. So 56 different names, and maybe, helpful in some ways, but was completely challenging. And what resulted was people procuring products where they thought they had procured that, for example, N95 mask, but they didn't happen to use the right indicator or identifier on that mask. So the mask they got was too small to fit 90% of the population who needed them. So standardizing and having one unique identifier for products like gowns or gloves or masks or sizes of mask, latex content, or etc., it is pretty critical. We don't have that. Generally, don't have it at all. And what that means is you can't now compare alternative products. If this is a unique identifier for the type of mask you're looking for, and it does not line up or match this one that you have available to you in the marketplace, then you can't know you're purchasing an equivalent product. What that led to was a lot of products got purchased no one could use. They didn't fit, or they didn't work, or they were of an insufficient quality. And it wasn't, teams went to the end of the world to get and find the products needed to protect our clinicians and our patients, but there were multiple and different challenges in order for them to do so accurately. And of course, as you would expect in this chaos, it didn't always work. What were some of the outcomes, and what was the impact of that existing supply chain capacity or fragility? It's pretty significant. And I am not suggesting these outcomes are a direct cause effect, but you have to consider all those types of features of fragility in our supply chain and our health systems. And I'll leave it to the group, and we can maybe talk about it. To what degree do we think it actually linked to, or were at least influenced some of these outcomes? One critical outcome was almost 20% of Canadians infected by COVID were actually our health workers. 81% of our deaths in Canada were seniors living in long-term care. It's 17,000 seniors, 177 seniors, and 32 staff deaths due to COVID. That is the highest in the world. It's a staggering 43% of our overall deaths. And the next highest or comparator country to us was Australia. They had a total of 28 deaths for their citizens living in long-term care, which was only 8% overall. So that was clearly one of Canada's significant failures, and one I would argue really have to be exceptionally focused on making sure never happens again. Surgery cancellations goes without, it's not too surprising. We had surgeries cancel. Over 500,000 fewer surgeries, of course, were performed over the first 16 months of the pandemic compared to with 2019. That number has snowballed significantly. And it's not just because of the cancellations it has snowballed, but of course the workforce shortages that Canada is now faced with that is overlaying that very, very significant number. So really what this is now on what's unfolding before all of our eyes is significant inequities in care and access to care, and those who were on what hopefully or were reasonable wait lists. Those are no longer, those patients have become very ill. The domino effect is if you've waited for that heart surgery or whatever the surgery might be 2 years longer than you might otherwise, they go into that surgery much more ill. They require longer lengths of stay, longer recovery times, much more complexity, much higher rates of risk. So it's really not just how many surgeries, it's the complexity and magnitude of the risk that these Canadians are now facing. And we see that literally unfolding before our eyes in our pediatric population as we speak. The impact on the nursing workforce, I call that out from the International Council of Nursing, is profound. And I expect that this global shortfall by 2030 is probably already realized and then some. I am seeing very interesting, perhaps some would say worrisome outcomes. Many countries are now going to lower income countries, recruiting nurses. Now, the exception I heard 2 weeks ago, I was in Germany, and what they're doing is setting up training and education facilities in both Mexico and Philippines. So they're not decanting nurses from those countries, but they're training people to become nurses and work in those languages. So we see a lot of global strategies to overcome that workforce shortage. I expect that'll continue for a very long time. So an emerging resilience, and when we think about fragility, so what is supply chain resilience? How can we make things better? Well, you have to start with defining on what is it we're trying to achieve. And really resilience in this that's really emerging for us as a research team is the capacity of a healthcare supply chain to enable care delivery without interruption, regardless of unexpected changes in demands for care or unexpected supply sources. So resilience is the ability to tolerate, whether it's a supply shortage issue like we've seen with pediatric Tylenol, or it's a significant demand in terms of patient care needs. The supply chain should be able to tolerate those, anticipate them, plan for them. As one of my colleagues in the US said, we need to move from just in time, which was our very focused on saving money, to just in case. What are the opportunities to ensure our supply chain can meet those just in case scenarios that will continue regardless of the degree to which the pandemic increases, decreases, new pandemics come online. So redundancy and diversification in supply sourcing and supplier capacity is absolutely front and center in supply chain resilience, not the only one. The use of stockpiles we saw was very, very common in every jurisdiction, including federal and provincial jurisdictions. People created incredibly impressive stockpiles almost overnight, renting warehouses and digitizing what's in that warehouse, because you can't just park it in the warehouse and wait for it to expire. You've got to rotate it and make sure it's used effectively and managed effectively. Otherwise, you waste a tremendous amount of money. The challenge with the multiple and different stockpiles we now have, however, is no single jurisdiction or entity knows where they all are. So federal, provincial, all have stockpiles of varying sizes, types, content. But we have no strategy on how do we manage those so we don't end up throwing them all out after 3 years like we found ourselves with SARS. Excuse me. Prioritizing Jurisdiction sourcing is also front and center in Canada. We have a number of Indigenous-led companies. We have Canadian-led companies and manufacturers onshore. We need to be able to support them, sorry, so that they can grow, thrive, be economic drivers for our economy, but give us the confidence that we don't have to go offshore to find critical supplies in the event of an unexpected change. Oops, I'm sorry, duplicate side. Oh, sorry, I seem to have this in twice. Advancing digital infrastructure, offering real-time transparency is critical. Apologies, I'm one of those people that's got stuck with one of these nasty viruses. This has become a very central priority for every province. I have not yet seen in my career the amount of attention on digital infrastructure, interoperability, data. So that may be a very important silver lining for us. Understanding where we are digitally, our digital maturity. There are many maturity tools that you can assess yourself, self-assess. There's a global network, HIMSS, of course, that has a tool just for supply chain maturity measurement. And that was an outcome of my research 5 years ago, interestingly enough. But now is a time where suddenly that's become important. Provinces realize the value of the digital infrastructure. And it's not just infrastructure within an organization like a hospital or long-term care. It's infrastructure across a system and across multiple systems. Because unless and until Canada can create that coordination across all of our stockpiles, all of our provincial supply chain teams, we're not going to be able to build that resilience, that ability to tolerate the fluctuations, the shortages, the ups and the downs, and make sure products are exactly where they need it and where Canadians need to be able to access care. That data now becomes centrally important for our provinces to make data-driven and data-informed decisions in how to strengthen supply chain resilience. Leadership that's coordinated and collaborative. This is tall order in a country where we have 10 provinces, 3 territories, provincially led systems and federal and systems the feds lead. Our focus has to be a way to coordinate and connect so that we're not competing with each other. We may be competing globally, but we're competing as a country, not as an individual organization or team. I think the other piece here is focusing on the at-risk populations. There was this natural inclination to prioritize hospitals based on what we saw on social media images early on. Countries like Taiwan, much different approach, where number one thing they did was identify their highest risk populations for COVID. They quarantined them early at home. They wrapped home services around them. Of course, that would be your elderly and your frail populations. Their rates of COVID were profoundly, almost negligible compared to ours, because they made decisions on risk, and the leadership decisions were very coordinated across all of the different cities, communities, etc. Interoperability, of course, the ability for that data to flow and understand where and how do we see the highest demands, highest risks, and that now becomes the key evidence to inform decisions. Is where we need to get to. That is not where we are currently today, but I think there's an openness that I have not seen prior to now. And it is our opportunity to really execute against, in my mind, to building this resilient leadership strategy. Meaningful engagement of the health workforce. One leader said, and I asked him, if you look back, and this was after wave 3, what might you have done differently? It's always easy to look in the rearview mirror, but sometimes looking and understanding the key lessons learned are just as important. And this individual said, the one thing I would have done differently is made absolutely sure I had the clinical workforce at these decision-making tables to help us really understand if you're going to make decisions like allocating and managing access to key products or equipment, that they help make those decisions for themselves with us, rather than having those decisions made for us. And that moral injury, as it was described by multiple and different stakeholders, It was profound, and I suspect has been a very key driver of the very significant numbers of resignations and challenges in retaining our workforce. The other thing I think we have to understand is the unique expertise and skill sets of a clinician. We train and educate nurses, physicians, clinicians to make the decisions on how to deliver safest care based on principles of infection control and many other scientific principles. We essentially removed that decision-making role from them. And no question, that was, I think, something we need to learn from and ensure does not happen again. And in restoring and supporting the autonomy of our clinicians to make those key decisions to protect themselves and protect patients will be fundamental to a sustainable workforce in future. I think lastly, on a feature of a resilient supply chain is equity and person-centered supply management. Resilience must focus and prioritize equitable distribution and support for every Canadian everywhere, but understanding that, and we saw this over and over in the pandemic, there were times of this pandemic when Alberta had huge significant struggles, for example, in the essential workforce. And then sometime later it was Ontario and the long-term care, or Quebec. It ebbed and it flowed, but being focused front and center on equity. Who's at greatest risk? How do we protect and mitigate those risks? Best possible ways for Canadians and our workforce, I would suggest, is a central feature of a resilient supply chain. And what does that really mean? What does it require? It requires very the material and logistical capacity to be agile, respond very quickly, very proactively and efficiently to mitigate risks to the degree it's humanly possible. Transparency of data. When people know what we have to work with, they're exceptionally good at trying to solve that challenge. When we keep it behind closed doors, or we just don't know because it doesn't exist, it makes for much less confidence in that system, and you get those behaviors we saw, like the hoarding or the buying things off the internet from very nefarious people selling things. So engaging in a much more transparent, meaningful, connected approach with our clinicians who do bring the expertise the rest of the system desperately needs, supporting their clinician autonomy, ensuring that supply distribution and allocation protects the most vulnerable, and tracking outcomes. If you don't get it right that first time or second or third time, tracking your progress and your outcomes quickly so you can pivot and change your strategy if it's not achieving the value it needs to. And this equitable person-centric supply management is probably the first and foremost feature of a resilient supply chain. And up until this time in this research, I have not found evidence that links supply chain resilience or strategy to what the outcome of the supply chain in healthcare really is. And it's about people's lives and ensuring we protect people's lives as equitably and effectively as we possibly can. So the emerging resilient features of supply chain are this: agility, responding rapidly, effectively, and focused on risk mitigation; collaborative leadership, whether that requires it to be centralized or just connected with data sharing, not for me to say, but the collaborative, so we're not competing with each other, is fundamental. We need to, it will drive towards that learning health system, the transparency, what's working, what's not, and how do we quickly pivot so that it makes it better for every citizen, every workforce member. Equity, decisions are prioritize equity, and just in case rather than just in time from a supply chain strategy has got to be where the future is. And I haven't found an organization or province that isn't driving in that direction. Where are we now? We've actually, since that study, now been funded for a community of practice initiative by the Social Sciences and Humanities Research Council. And this means bringing a number of partners together to advance supply chain resilience, strengthen workforce sustainability, design, implement, and scale those strategies and those solutions to overcome these challenges, and not doing that from a top-down, here's the research, just do what I tell you, but bringing all these partners together into work groups to work together to create the solutions that are going to work for every jurisdiction, province, and team. So we have a sourcing and procurement work group led by JP Prasad out of Alberta, I'm leading the leadership and policy. Colleen Medj out of Manitoba is leading digital supply chain. Judy Birdsall and her team out of Alberta are leading a citizen forum because citizens have a lot to contribute here. Workforce sustainability led by Susan Moffat-Bruce, the CEO of the Royal College of Physicians and Surgeons, and Kathleen McMillan, one of Canada's foremost nursing leaders, to drive towards sustainability, and domestic supplier network led by Ron Johnson out of Newfoundland, and Jay Myers, the CEO of our NGen manufacturing network. Number of partners. We are just getting this underway, and I open an invitation to any and all of you if you would like to participate or engage in that community of practice. By all means, please contact us, and I'm very grateful to have your expertise. So with that, let me close, and I very much look forward comments, questions, thoughts, ideas, things we haven't thought of. Over to you, Kellen.
Thanks so much, Dr. Snowdon. Yeah, so I encourage everyone. I see there's already one question in the Q&A function, but please,
sorry.
Oh yeah, those poppers. Please submit your questions to the Q&A function now, and we'll get started on a bit of a discussion. So one question that I see here from Aaron Kerwin is, thanks for such an engaging presentation. I'm wondering if you think there's a trade-off between the agility that comes with small decision-making units versus the efficiency and equity that is possible with more coordinated decision-making. Do we lose agility with more centralized supply chain strategies? Is this a risk?
Yeah, it's a good question. And centralization doesn't mean there's not, apologies, the doorbell rang and dogs seem to want to answer it. It does not mean that decisions are made for the entire province. What we've seen in those provinces that do have a more centralized decision-making model is they are connected to an entire network of the communities they serve. So the knowledge sharing and the transparency and the data, it is very open and engaged, and the decisions are made that best reflect the needs of every organization. So I think what didn't happen was the centralization. What we saw was every organization, community player, small, large, medium, all trying to make a decision in a profoundly chaotic environment. And what that meant was they were competing with global nationals. Like, it just didn't work. And the best example of that is our long-term care and home care colleagues. They had no chance of competing with supply chain teams, long and deep expertise in the rest of the world. So there may be a trade-off. I don't see it as a trade-off. I see it as just a way to organize it effectively, quite frankly.
So you think we already have kind of the more detailed, less centralized folk, but we don't have the centralized folk. So we need both working together.
In a time of a crisis of this scope, scale, and magnitude, and this won't be the first, this is not the first one, of course, it's one of the largest ones. It's not the largest. We're going to find ourselves happening again. I can't imagine going through the chaos I saw and heard about with teams on the ground in every community in the country, struggling to figure out, how can I help this nurse protect her from, or make it possible for her to deliver great care. So the chaos and the challenge with that, I think we have to get to a strategy where, under particular conditions and types of scenarios, here's where the collaboration and the centralization, if you will, helps to inform very important and very strong decision making.
Great, thank you. So another question, great presentation. Given the differences in healthcare delivery across provinces and territories, how do you propose provinces coordinate the movement and tracking of supplies across the country?
Well, actually, the private sector does exceptionally well distributing products across every health system. So I think that infrastructure and expertise exists. The variation in care delivery and population health needs and all those things is completely not likely to change anytime soon. This is not a one size fits all. This is a coordination and a connectivity so that one organization or system or team has an ability to know how might I connect with or work with another who could be helpful, because we both need to get to the same outcomes. It's really more of a collaboration strategy, if you will. But how do you do any of that without any data to work from? Like Ontario had no line of sight to, boy, could Alberta be helpful? Because we're really struggling on our long-term care population to the point where they had to call in the military. If there had been some perhaps frameworks, models, emergency response team strategies, perhaps to inform that way forward way more proactively than it was. I would suggest, and I don't have the magic bullet solution. That's exactly what the community practice is setting out to achieve. But those are the kinds of frameworks, I think, models, approaches that we've got to design and make sure do work for all the different provinces, stakeholders, teams within them, and organization sectors. This is long and tall order for sure.
Yeah, great, thank you. So thank you, Anne. I understand that supply chain policies must be incorporated into the EMC, emergency management cycle. Do you agree? Or is that kind of one of your main points?
Absolutely. I mean, emergency management cycles probably vary as much as our provinces do. The question is, how do they all connect? So yeah, absolutely. So supply chain is not, prior to this pandemic, really been on the radar screen of most organizations. I've been in this research space for 10 years. I used to have to tell people what a supply chain was. Thankfully, I don't have to do that anymore. The question now is, where and how does it need to get integrated, embedded in those emergency management cycles, those disaster preparedness strategies? How do we practice those? How do we learn from them, as opposed to what happened in SARS, where we had, a much smaller scale, but devastating outcomes for many as well, but we didn't learn from it. So how do we take the lessons learned, the hard, very hard lessons learned, and embed them into the fabric of our health systems as a country so that we never find ourselves here again? That's the question. Do I have the answer? I wish I did. But collectively we do. And I think that's the critical piece.
And do you see people are taking kind of advantage of the fact that people are more aware of supply chain and it's more in the media? And do you think that's starting to happen, or do you think that's actually kind of hampering the situation?
Well, I think it's tough to know that. I can't say that I have data that would say yes, they are, they're not. There's no question a much more crystal clear awareness of the critical, asset of a supply chain. I think people now realize the impact on people's lives it has. I think there's a sensitivity to how critical it is that a supply chain capacity supports our workforce. But our health systems are really struggling with 200% increase in supply shortages. Like every week there's new supply shortages, 200% more often than they were prior to this pandemic, on top of severe workforce shortages and multiple challenges of, we're seeing seasonal flus and viruses. I mean, it's not like the health systems had a chance to catch their breath, sit down and really do some good deep thinking as how could we make this better? We're building the airplane literally as we fly it, almost still. I don't know how we could get out from under it and avoid it, but I do think we have to recognize just how much pressure our systems are today. How do we support and enable some of this work to get done to support them moving forward without doing it for them when they don't feel part of the solution, right?
Hi, Anne.
Hi, Chris.
I'm interrupting because I don't, as a panelist, I don't actually have the ability to chat my questions into the Q&A. No, not your fault. The question I have kind of follows up on the previous one. Do we see similar issues with the supply chain in other countries? How much of this is because of our federalist system or the inability to really coordinate things, or is it just like slightly different problems that all kind of lead to the same bad outcomes?
Yeah, it's a good question. It's a tough question to answer because the complexity, like if you think of, companies, first of all, the supply chain is global, right? There's no country in the world that isn't having to navigate the challenge of global suppliers of critical products. And in some of these product categories, they only come from one place. In many cases, gloves in Malaysia is a good example of that because of the sources of latex, right? But the structure of systems, the size of their markets that drive relationships with manufacturers is it's significant, right? Canada's a small market for most companies. US is a huge market. So if US is calling and says, hey, I need all of your product X, they're more likely to get it than a Canada who says, yeah, I need some too. Germany, the Tylenol shortage is a good example. I was traveling and for the first time when I'm travel, I have colleagues say, Anne, can you find any kids Tylenol in Germany while you're there? Well, I went into a pharmacy in Germany, which was entertaining. And I asked the pharmacist, what do you have any available? And they looked at me funny and they said, we haven't had kids Tylenol for a year, lady. Don't you know there's a worldwide shortage? So I like, who knew? I didn't know. So it is a challenge, and it is all, market dynamics and sizes of market and how lucrative that market is. What I am starting to see among some of the Canadian centers, though, is going right to these manufacturers and creating a relationship with them that's beyond just, hey, we need to buy X number of whatever it is, masks or children's Tylenol, working with them and purchasing their capacity. So, we have insurance policies that if I get in a car crash, you will help me cover the cost of the car damage, right? Going to a manufacturer and say, if I need to ramp from my current order of 1,000 a day to 50,000, I want to buy 25% of your manufacturing capacity as to be proactive and prioritized for your product. And that's a good idea. Is it viable and feasible for every company in every province and every country to do that? I don't know. But, it's a innovative, different, out of the box thinking that I think we have to do, because we don't have a lot of the onshore products we need. We don't have a ability to start manufacturing some of them based on access to raw materials. So we do have to think, in that just in case mindset. And I think every country is doing the same, but the Europeans do that very differently than the North America, and different again from Asia Pac. So the variability is really high to be able to answer that question definitively.
We have another question from the audience. So the supply chain is essentially a culmination of millions of individual production decisions by firms in response to consumption choices. Is it realistic to expect that a centralized supply chain system is feasible?
So I think you have to define what we mean by centralized supply chain system. When I say centralized supply chain system, I am suggesting only that if you have 10 provinces, 3 territories, and a lot of hospitals and agencies in between each one of them, is there a centralized knowledge repository, data access, transparency to who has what, and how do we collectively make decisions to advance and to make sure Canadians have what they need? We saw the centralized strategy with vaccine procurement. Canada did very well on procuring vaccines early and in sufficient qualities that Canadians got access to vaccines in many cases before many other countries. So for me, I think it's defining, what do I mean by centralized? I don't mean one guy in an office with a team of 12 people making decisions for the rest of the country, but a centralization of how we manage and respond to these kinds of very dramatic, unexpected, and quite frankly, threats to people's health and wellness. And the vaccine strategy was one good example of how Canada did that well. How do we learn from that and build onto it, so it's not just for procuring vaccines? Maybe there's a small group of critical products that should fall under that same kind of approach. I don't know, but centralized is a loaded word, and I would be cautious as to how I'll try and be cautious as to how I'm defining it.
Interesting. So another question. So thank you for the presentation. An important point is the environmental aspect of products.
Right.
During the pandemic, thousands of tons of product waste were wasted, which was not eco-friendly, and it seems there's no intention toward enhancement of the supply chain to have environmentally friendly products.
That's a great question. The landfills, and even I talked to some colleagues in the construction industry who have struggled with water infrastructure being plugged with people's masks, throughout this pandemic, a huge impact environmentally. Up until this pandemic, there has been no policy framework that requires a health system to either measure its climate impact, carbon capture, or any of the above, or consider what percentage of products need to be eco-friendly. It was never even contemplated. There is now, more recently, France was one of the first countries to design a climate impact strategy and policy framework for health systems in that country. Other countries I'm seeing quickly follow on. It may be interesting to know that Canadian manufacturers actually designed eco-friendly masks, surgical masks, that exceeded the performance of the good old blue surgical masks that we're all familiar with. They're 100% biodegradable. The problem we have now is getting health systems to buy them, because there's no policy framework that says they have to, or they should, or it should even be measured and considered. And yet health systems do account for, I think it's 8% of the impact of climate change compared to other business sectors. And that came out of the France study, so don't quote me, but you're absolutely right. It needs to be embedded in frameworks so that there's an accountability for health systems' impact on climate, and particularly with all our disposables. The plastics disposables are remarkable, actually, how significant those are. But up until now, it has not been on the agenda and the radar that I could find, for sure. But I couldn't agree more. It certainly needs to be. And there are Canadian companies that sell those great eco-friendly masks. So encourage people to think about that.
Yeah, it seems like a good time to start, as we're changing and updating these supply chains, start considering this as well. So just looking at the time and the fact there are no more questions, I want to thank you, Dr. Snowdon, for such a great presentation, and everyone else for your discussion and your questions. I think it really added to the presentation today. And just want to encourage everyone to join us for our next topic, which is on December 15th at the same time, 10 a.m. Mountain Time. And that will be presented by Drs. Frank Milne and David Longhorn. And yeah, thank you, everyone, and see you next time. Thanks, Anne.
Thanks, everybody.